Welcome, and thank you for joining us today. In primary healthcare, we're often the first point of contact and the steady presence patients rely on. When HIV and renal impairment intersect, the decisions we make become even more critical. Today's session explores a practical PHC approach, early identification, appropriate monitoring, and treatment considerations that support safe, effective care. Because behind every guideline is a person, and behind every decision is the opportunity to improve outcomes. We're glad you're here. Let's get started.
Hey, colleagues, welcome. It's a brand new week, but it was new yesterday. Now we are within. It's already a Tuesday. Just to say thank you so much for joining us this evening. Ooh, I've got my screen glasses on. Yesterday, I had a rather long day in front of the screen for almost the whole day until late, just trying to work and push. So today I remembered that hey, I need my screen glasses so that I can be energized a bit. Yeah. So thank you so much for joining us this evening. We are looking at seminars in HIV care, and I can tell you that nowadays I'm no longer a lone ranger. I am with Dr. Christy Jackson. Hi, Christy. Are you able to say hi so that colleagues can hear your voice? I know we were
Hi
chat.
everyone. Yes, I'm trying to turn the video on. Is it working?
Hey, there we go. We can see you. Are you well?
Yes, I'm good, thanks.
I
I
sus-
hope my voice holds because I've been talking the whole day, but we'll be strong.
No, it sounds good. Are you in Bombela? How's the weather there? You seem
Yes,
to
it's hot.
be,
Oh, it's
yeah.
very hot.
I miss that weather. Trust me. Yeah, awesome. Thank you so much. Yeah, so welcome, colleagues. I'm not going to waste a lot of time. Maybe just to tell you a little bit about Dr. Christy there. I won't read the profile. What I can tell you is that she's very experienced and she leads HIV programs, and so you're going to learn a lot from her. Yes, clinically, the clinical side will come through, but I think what you're going to appreciate more is the real practical side of HIV care. So Christy is part of our faculty here at the clinical care platform. Not only does she do these kinds of webinars, but she also facilitates probably all the diplomas where HIV needs to be discussed. So, child health, obstetrics, and also the diploma in HIV management. But today she's here because she does have a passion for primary health care, and we're going to look at what are some of the important things that we need to be doing at that level. So, on that note, I'm not going to waste a lot of time except to officially welcome Dr. Christy on board. And Christy, yeah, welcome. I think you can take us from here. Thank you so much.
Okay, let me try to share.
Yep, it's coming through.
Know if it's visible.
Yes, 100%. Thank you so much.
Okay, perfect. Let me just get these screens all sorted.
Yeah, I'm sure it's my screen's confusing you there. I've switched them off.
Fine, it's all good now. Good evening, everyone. It's so nice to be here with you again this evening. I will start this by saying I am not a nephrologist. I'm not a renal specialist at all, but I've been working in the field of HIV for a long time now. So I've picked up a few things on how renal impairment and HIV care intersect. So I'm just going to try to give a bit of an approach, mostly aimed at primary care, but some of it can also be applied at the hospital. So for those of you who are working in hospitals, I'm hoping you will also get something out of this. But just recapping some basics and hopefully adding a couple of new things that you might not have known. Okay, before we start, I just want to check exactly who is in our audience.
Yes.
I
was about to
can
ask
you
you.
just... Yes, I wanted to I couldn't remember what was my first slide. Can I just ask everyone to tick if you're a doctor, if you're any category of nurse, whether you're a staff nurse, enrolled nurse, professional nurse, you can tick nurse. Anyone in the pharmacy industry, if you're a pharmacy assistant or a pharmacist, clinical associates, any other category we have. If we missed you on the list, we are very sorry. You can type in the chat if you are not appearing here. We just wanted to get an idea of who exactly is here.
So GPs are not doctors. It's interesting. They're typing there in the chat.
No, please, whether you're an intern or a consultant or anywhere in between, private, public sector, you can all just tick doctor.
See, radiographer. Welcome, our dearest radiographers.
Okay. Very interesting.
Yeah. Okay.
Okay. How many people do we have? We have about 600, more than 600 people on. Okay, I know everybody haven't answered, but I think we've got an idea. We've got quite a lot of doctors, quite a lot of nurses, and a few numbers of the other professions. Okay, I'm happy with that.
And I welcome our vet, Tato, our vet. Welcome, very interesting. Felicia as well. Okay, interesting.
Yeah, I'm not seeing the chat right now, so if there are interesting things there, you can mention. Okay, no, that's very interesting.
Thank you.
Thanks, everyone. Okay, let's get started. So we have a couple of cases here. The first one is quite a short one. The second one is a bit longer, just to help us follow through. So this is our first patient. He is a 45-year-old male. He was newly diagnosed with HIV last year. He started TLD on the same day at his local clinic. His baseline creatinine was 90.
Okay, Christy, continue.
Okay.
Yeah.
Let me know if there is a problem. My connection should be quite good. Okay, so this is our first call. When should we repeat his creatinine? Should it be after 1 month, 3 months, 6 months, or 12 months on TLD? If you're not sure, you can take your best educated guess. Okay, I see most people are on the right track. I'm going to end it in a couple of seconds. If you can see the poll, please rather click on the poll instead of writing in the chat. The poll should be popping up on your screen, and then you just click on the right answer and click submit instead of writing on the chat. Because I see there's lots of answers coming through on the chat. Okay, so this is what the audience is saying. Most people were saying 3 months. That is the correct answer. So for a normal patient who had normal baseline creatinine, started on tenofovir, we want to repeat his creatinine test after 3 months so that we can see how his kidneys are doing now that he's on tenofovir. Okay, let's go on. So when are all the different time points that we should be monitoring renal function in a patient with HIV? So we do it at baseline for all clients who are 10 years and above. Why are we saying 10 years and above? That's because most likely these people were initiated on a TLD-based regimen. So because TLD contains tenofovir, tenofovir is the drug that could be nephrotoxic or toxic to the kidneys. So children younger than 10, they're not going to be on a tenofovir-based regimen. So we don't need to do it at baseline for our young kiddies. If you are initiating a 3-year-old or a 6-year-old, you don't have to do a creatinine because it's not relevant to them. Only for those that we're going to be starting on a tenofovir regimen. Then, this was the poll question. We repeated 3 months after starting a regimen that contains tenofovir because we want to see if the kidneys are coping. They were normal to start with. We're happy with that. But are they still coping now that we've added tenofovir, which could cause renal impairment in some people? If that 3-month creatinine is normal, then we will repeat it annually. So basically, every year, together with the viral load, we will collect the creatinine as well. So in the old days, we said that 12 months on treatment, and then every 12 months after that. Remember, with the new 2023 guidelines, we are allowed to do our first annual viral load as early as month 10 because it works a bit easier with the 3-MMD issuing that we do. They will usually come on month 10 and again on month 13 or month 16. So if we see them at month 10, we can collect the viral load and always then do the creatinine at the same time. And if it's normal, then we just continue repeating it once a year just to check what's happening. This is from the HIV point of view. I know there are other chronic diseases that can also influence the kidneys, but for HIV, this is our approach. If it's abnormal, of course, we should do it more frequently. It will depend how abnormal. If it's a really sick patient admitted in hospital, you might repeat it after a few days. If it's a stable patient at the clinic, you might repeat it after a month or 2. It will depend on the situation, the contributing causes, and whether we think it's acute or chronic. But it will be more frequent if it was abnormal and we're busy working the patient up. So this was our answer. After 3 months on TLD, well done to everybody who got this right. Easy question to start off with. So I've been talking about creatinine now, but if you look at the lab results and all the different things, you'll see we talk about different words. We use different words when we talk about renal function. Sometimes we talk about creatinine. Sometimes we talk about eGFR, which is the estimated glomerular filtration rate. How fast are the kidneys filtering the urine? And sometimes we talk about creatinine clearance. So what exactly is the difference between these? When do we use which one? So for the majority of our adult patients, 18 years and above, we can use the eGFR, which is calculated by the laboratory. As long as you write the date of birth on the lab form, and the person is 18 years or above, the lab will calculate the eGFR and they will write it there for us. They will print it. They even have 2 different formulas, the MDRD and the CKD-EPI, both of them are appearing there. And we can make our decision based on this result. As long as it's above 50, we can continue with the patient on TLD, on tenofovir. If they are pregnant, we cannot use the eGFR because the formula, remember, your physiology changes when you are pregnant. Your blood volume expands, the body weight changes, and it's not all the mother's weight. There's now also the baby and a placenta and all of that. So the formula is not accurate in pregnancy. So in pregnancy, we switch. Instead of using the eGFR, we look at the actual creatinine number, and it should be less than 85. Remember, creatinine is a waste product. So if the waste product goes up, then we are worried that the kidneys are not excreting the waste product quickly enough. So we want this to be lower than 85, where the eGFR is the rate that the kidneys are filtering. So the higher, the better. It's filtering very well, very fast, then we're happy. If filtration slows down, that's when we start being concerned. So don't get confused between the greater than and the less than. And then thirdly, for our adolescents between 10 and 18 years, this age group, we do need the creatinine or the renal function because they are already eligible for tenofovir, but the lab won't calculate the eGFR for them because you need different formulas in adolescents and you need some other inputs. You might need the actual weight, or you might need the height or some other parameters. So for these ones, us as clinicians, we have to calculate it ourselves. And there are lots of formulas. There are complicated formulas. I decided not even to write it here on this slide. The easiest by far is to use one of the online calculators. Just Google Cockcroft Gold for 10 to 16 years old, or the MDRD formula for 16 to 18 years old. It will just ask you, it will give you like a simple form on your phone. You just input a few numbers, like the age and the creatinine and so on, and it will give you the answer. So you can do the actual math if you want to do the math, but the online calculators are the easiest. And then for our teenagers, the creatinine clearance should be greater than 80. So for other adults, we say greater than 50 is okay. But for adolescents, the kidneys are still really healthy and they filtrate urine really fast. So it should be way above 80. If it's below 80 in an adolescent, that's already too low. Luckily, we hardly ever see renal problems in our adolescents, but you might pick it up if it is less than 80. So that's the difference between eGFR, creatinine, and creatinine clearance. Slightly different population groups where we use each of them. Okay, now we have our second patient. She is a 68-year-old female. She's been on ART since 2019. She's also hypertensive and diabetic on treatment, and she's also following up at her local clinic. These are her last few eGFRs. So 2023, it was 55 mils per minute. 2024, it went down to 41. And now the latest one from last year was 45. So it went up again slightly. But you can see it started off being a bit low, and it's now a little bit low. We should be a bit concerned about what's happening here. So just as a reminder, we are usually happy if in the HIV world, we are happy if we see eGFR above 50. So when this lady came, when the eGFR was 55, we would have been happy. Yes, you can get enough of it, no problems. Look at this reminder of stages of renal failure. If the eGFR is above 90, then we actually have normal kidney function. Between 60 and 89 is actually already stage 2 with mildly reduced kidney function. In some people, it can be normal to be between 60 and 89, but it could be the first sign of a slightly decreased renal function. And then once you are between 30 and 59, that's already stage 3, moderately reduced kidney function. So even our patient here with the eGFR of 55, we were happy to give her tenofovir in 2023, and we were correct according to the guideline. Actually, she was already in stage 3 renal failure. So we mustn't underestimate and overly normalize slightly abnormal kidney results. I know that many times the laboratory will not give you the actual eGFR. They will just say greater than 60. And in that case, they mean the patient is stage 1 or stage 2. We don't really have to do anything about it. And it's perfectly fine in most cases. If it starts being below 60, we do actually really have to keep an eye on the renal function. So that's stage 3. Stage 4 is if the GFR is between 15 and 29, that's severely reduced, and less than 15 is very severely reduced kidney function. We normally call it end-stage renal failure. Just as a reminder to put it into perspective a little bit. Okay, so if we look at our patient here with her last few eGFR, do we think this is acute or chronic renal failure? How do we decide between the two? So there's a lot of clues that can tell us whether it's acute or chronic. Acute, usually they would have normal previous lab results. And now this is the first time that the renal function is abnormal. Compared to chronic, where you would normally find previously abnormal results, like in our patients. There's been a trend for a couple of years in this lady. If you have access to ultrasound, if you're at the hospital, that's why I put the little star there, this is for hospital, you might find normal sized kidneys on ultrasound because the kidneys are actually okay. They're just having big problem right now, but previously they were fine. In chronic renal failure, you might find small kidneys on ultrasound, or they could be enlarged even, but there will be something to show these kidneys have been abnormal for quite some time. With acute renal failure, the HB is usually fine. With chronic renal failure, you might have anemia because of decreased erythropoietin, EPO. It's produced by the kidneys. It also helps with blood production. So if this is disrupted by the renal failure, you might see anemia of chronic disease in your patient. Acute renal failure, you might see a patient with hyperkalemia, high potassium, or acidosis. Both of these are quite dangerous conditions. Usually we'll pick it up from bloods done at the hospital or blood gases, things like that. And this is because the metabolism, the physiology gets disrupted by the acute renal failure and the body is not used to compensating. So the body starts spinning out of control, so to say. Whereas with chronic renal failure, even though the results might look bad, they might be quite stable. They might have a normal potassium, they're not acidotic, they look quite okay where they are sitting there in your room. Acute renal failure, they might not have any chronic comorbidities. Chronic, they might have. This is not an absolute, but it can give you a bit of a clue. Comorbidities that could also affect the kidneys, like hypertension and diabetes. And then with acute renal failure, you'd have a short duration of symptoms, and with chronic, you'll have a long duration of symptoms. So I must say, our patients don't read textbooks. So our patients don't always know in which columns they must put themselves and stick to one column. So you might find a patient with a bit of a mixed picture. But it's just to give us an idea, because knowing whether it's acute or chronic helps us to find the actual underlying cause for the renal failure. Because renal failure, the kidneys don't just start failing by themselves. There's some things that happen to that kidney to make it stressed, to cause renal impairment. And we want to try and find that cause so that if it's a reversible cause, we can start reversing it. And if it's not a reversible cause, we can try to slow it down or manage it as best as possible. So that's why we try to think about acute versus chronic. Okay, so that one is applicable to our patient. She's also had a long duration of symptoms, and I think the comorbidities as well. She also had hypertension and diabetes. Then another way of thinking of the causes of renal failure is asking ourselves, is the cause pre-renal, intrinsic renal, or post-renal? So this might sound confusing to some people, but it basically means where in the process of the kidneys is the problem. So if the kidneys are not perfused properly, that would be pre-renal failure. You would typically see a very high urea and a high creatinine. If it is intrinsic, it means that there's damage to the actual renal parenchyma, the renal tissues. You will see a increased urea and creatinine. And if it's post-renal, it's usually because the urinary tract is obstructed. So in that case, you will see a high urea with a very high creatinine. Also, our patients don't always see these tables and see how they should place their urea and creatinine to fit into our table, but it helps us to think along the right lines so that we can look for the underlying cause. It's not easy. There's often overlap, but it helps us a bit. So I'm just going to show you briefly about some of the causes that can contribute to each of these three. So pre-renal, we said this is when the kidneys are not perfused properly. So this could happen if the patient is hypovolemic. What makes them hypovolemic? It could be dehydration, blood loss, burns, for example. A patient in shock, a patient with sepsis, renal artery stenosis, and some drugs as well, like ACE inhibitors and NSAIDs, can lead to this kind of picture. This is often more of your acute renal failure kind of pictures. Then we've got intrinsic renal failure, where the kidney tissue itself gets damaged. So it could be renal ischemia, for whichever reason the kidneys are not being provided with enough oxygen. It could also be sepsis, hypertension, especially if it's long-standing uncontrolled hypertension. Some drugs, including tenofovir, I put it in red because it's linking to our HIV topic here tonight. HIVAN as well. HIVAN stands for HIV-related nephropathy, or HIV-associated nephropathy. So that means the HIV virus itself is causing the kidney problem, not the treatment for HIV, but the HIV virus itself. We saw a lot more of this before we had proper ARV programs, but sometimes in patients who present late, we can still see it. Glomerulonephritis as well, interstitial nephritis, hemoglobinuria, thrombotic microangiopathy. There's many other causes. You don't need to know all the detail of all of these. If you think the patient has intrinsic renal failure, you might have to think of doing a workup to try and exclude or confirm some of these as the underlying cause. Quick word about the nephrotoxic drugs, since we mentioned them now. Remember which drugs are all nephrotoxic, and it's things that our patients are often taking. All the NSAIDs. You know how many patients get Brufen over the counter or diclofenac, indomethacin. Sometimes we prescribe it to them, sometimes they get it over the counter. Really shouldn't be giving it to them if they already have underlying renal failure. Our aminoglycosides as well, amphotericin B if the patient is getting treatment for cryptococcal meningitis, and then of course tenofovir. And remember with tenofovir now, we actually have two different types of tenofovir. We've got PDF, that's the one that we have in the public sector at the moment. It's the one that's part of TLD. And then we also have the new one called TAF. So TAF is available in the private sector. In the public sector, it's available in some provinces and as buyout out. But hopefully with some of the new tenders that will come later in the year, we might also be able to get access to TAF. So we'll say a few more things about TAF later on. They are cousins of each other. TAF is a little bit friendlier on the kidneys compared to tenofovir. Okay, and then the ones that can cause obstruction, post-renal failure. You can think of things like prostate cancer, prostate hyperplasia, any other cancers of the urogenital tract, the kidney, ureter, bladder, pelvic masses for other reasons, pelvic lymph nodes, anything that causes a mass in the pelvis that cannot cause an obstruction, you can put in this category. If they have urinary tract schistosomiasis or TB, which can cause strictures of the urethra, that can cause obstruction, and even kidney stones. So keep these things in mind as well when you work your patient up for the cause of his renal failure. So there's a lot of things to think of. Now we need to be realistic. We are at the primary healthcare clinic. What can we actually do at the PHC? We can't just do nothing. Maybe we want to send the patient to hospital or refer to the doctor, but where do we start? So here's a few things. This list is by no means comprehensive. Please don't take it as an absolute and say this is the be-all and end-all. Do follow your local protocols as well, but it's just some ideas of where to start if you're at the clinic. Urine dipsticks is the first one. Please don't have a patient with renal failure and you haven't done dipsticks. It can tell you so much. If there's leukocytes, you know that there's an infection that could be treated. If there's blood, there could be damage higher up in the kidneys. There could be bilharzia involved. If there's proteins, it shows us that the renal tissue could have been damaged because the protein is a big molecule. So if the proteins are able to leak out, it means there's a damage somewhere higher up. They're not supposed to be able to leak out. That shows a kind of a structural damage in the nephrons. And then if there's glucose, maybe your patient is actually an uncontrolled or undiagnosed diabetic, which can also cause kidney issues. So please always do dipsticks. And you can also send a sample away to the laboratory. If you think infection might be a contributing cause, you can do an MCNS. You can do a protein creatinine ratio, especially if there was protein in the dipsticks. You can even do a bilharzia if you're in a bilharzia area. Even if there was no blood, you can still do bilharzia in the urine if you're in a bilharzia endemic area. Then we said renal failure, chronic renal failure can cause anemia. So if you think your patient has chronic renal failure, it might be worth doing an HB or a full blood count. You might even add on iron studies to see if it is necessary to add some iron supplements to your patient's treatment plan. This won't be the cause of the renal failure. It can help support the body while the patient is recovering or still having chronic renal failure. Then we want to check a hepatitis B surface antigen. We can even check for hepatitis C. Hepatitis B can cause kidney disease, especially if they're going to be sent for dialysis. We would need to know the hepatitis status. And then obviously, if it's an HIV positive patient, if they have hepatitis, we have this conundrum because we know tenofovir treats hepatitis, but also tenofovir is bad for the kidneys. So it's really important to know which conditions we are dealing with when we make our treatment decisions. Calcium would be another one we can check, because in chronic kidney disease, the calcium can be low. Again, it's not a cause of the renal failure, it might be a consequence of renal failure. So if the calcium is low, it gives us the opportunity to add calcium supplements to the patient. Then if it's a female and she's not had, sorry, I don't know why there's calcium there. It should just say cervical cancer screening. If she's not had cervical cancer screening in the last 3 years, or if the previous one was abnormal, please, let's follow that up. Let's do a pap smear if we need to, because if she has a pelvic mass because of a cervical cancer mass or something like that, that could also cause obstruction. Same with a man. If they've got symptoms that we might suspect prostate obstruction, we could consider doing a PSA as well. Okay, so those ones definitely I think we can do at the clinic. There's many other things we can do. You won't necessarily do all of these at the clinic. You probably won't do any of these at the clinic. And if you're at the hospital, you won't need to do all of these for every single patient. So again, I know many of you are sitting here taking a picture of this slide. Please don't take a picture of the slide and say this is the be all and end all. There might be additional things you need to do on top of this. There might be some of these that's not applicable to your patient. So it will depend on the picture. You might do a PTH to look for hyperparathyroidism. If it's an acute kidney disease, you might want to do things like blood gases, potassiums, chest x-rays. If you have ultrasound available, that might be useful to tell us something about the size of the kidneys. I think this is also a repeat. Vitamin D, because the chronic kidney disease can cause bone and mineral disease. It changes your phosphate metabolism a bit. So we might have to supplement vitamin D in patients with severe chronic kidney disease. If you suspect autoimmune conditions, you can do a whole autoimmune workup. There's more other tests that fit into this little block. Blood cultures, chest x-rays if there's sepsis. So think about what your patient needs. You might use some of these. You might need other things that's not on the slide. But some of these would be more on a hospital level, where at the clinic level, we can start with these basics at least. So back to our patient. What would be the correct ART regimen for our patient now that her eGFR, the latest one, is 45 mils per minute? Let me find our poll again. Okay, so should she get TLD? Should she get ALD? So ALD is the fixed combination with full dose, 600 abacavir, 300 lamivudine, and 50 dolutegravir. Should we give her single doses and decrease the lamivudine to 150? Or should we give her single doses and decrease the lamivudine to 50 milligrams? Okay, I see some people are voting, some people are still thinking. Again, please choose the option in the poll and click submit there. Please don't type it in the chat because it's very difficult for me to see the chat. Okay, we are assuming our patient does not have hepatitis in this case.
It's all interesting.
Okay, I'm gonna, yeah, good thought for whoever thought of that. Okay, I'm gonna pause it here. Let's see everybody's results. Okay, so most of the class, more than half, voted for ALD, 1 tablet once a day fixed combination. And then some people were brave enough to give TLD and some people wanted to give single doses. Okay, very interesting. Let's get these slides moving again. Okay, so the big question is, when can we give tenofovir? When should we stop or avoid tenofovir? And this patient would not be eligible for tenofovir. So in adults, if the creatinine clearance or the eGFR goes below 50, we'll stop tenofovir if it's already there, or avoid starting it if they're not yet on it. If they're pregnant, we said if the creatinine is above 85, and if they're adolescents, it will be below 80. So remember these ones. So Our Lady would not be eligible for tenofovir. So what do we do then? So if the eGFR is below 50, like for our patient, it's 45, we'll stop the tenofovir, but we have to replace it with something. So which drugs do we have that are renal-friendly alternatives? So the most common one that we have is abacavir, of which we can give the normal dose of 600 milligram. We don't need any dose adjustment for abacavir. They still need the 600 milligram. And the other option would be TAF. So if you are in the private sector, or if you are in a province where you have TAF available, or when it does become available on tender for everyone, we would be able to use TAF as a possible alternative, as long as the eGFR is above 30. So TDF will be below 30. Below 50, we have to stop it, and then below 30, we have to stop TAF as well. For our patient here with the GFR of 45, we would be able to give her either one of the two. So if we only have abacavir available, then we will choose abacavir. Then what about the lamivudine? So this is where people get confused. So please look carefully. This one you can take a picture of if you think you're going to forget this. So this is very important. If the eGFR is above 30, we can and we should give a normal dose of 3TC, lamivudine. Please don't give a low dose of lamivudine if the eGFR is above 30. You will be underdosing your patient. You will be giving a higher pill burden because now you're giving single drugs. And those single drugs are not always easy to find these days. So we have some supply issues with the singles. So please don't waste the singles on somebody who doesn't need it. Please, they can get 300 milligram, which means they can get the fixed combinations. They can get Dumiva plus DTG, or they can get the ALD fixed combination tablet above 30. Yes, they've got renal failure, but they can still get the normal dose of lamivudine. It's only if the eGFR becomes less than 30. So if they are stage 4 or stage 5 renal failure, that's when we have to start decreasing the lamivudine. So if the eGFR is between 15 and 29, this is stage 4 renal failure, we decrease the lamivudine to 150 milligram daily. So that is one tablet. The lamivudine single tablets come as a 150 milligram tablet. So we'll have to change everything to singles now. So you'll have to give your dolutegravir 50 milligram tablet. You will have to give your abacavir single tablets. And I think abacavir comes as a 300 milligram tablet. So they will need 2 abacavir tablets to make 600. And then they one lamivudine tablet. And then if they become stage 5 renal failure with the eGFR of less than 15, we've got 2 options depending what we have available. If we've got a tablet available, we can give them half a tablet, which is 75 milligram. Or if we have syrup available, we can give them 5 mils of syrup, which is 50 milligram. Either one of these options are okay, depending which one you have available in your facility at that point. Okay, I hope you all will remember this. I've seen so many patients who are being underdosed on lamivudine, or they know that people phone and say, we don't have lamivudine single drugs in stock. The eGFR is 45. What can we do? Then we say, please give them the fixed combination ALD. That's what they really need, not the decreased dose. Okay, so this was our correct answer. The full doses of abacavir, lamivudine, and dolutegravir for Our Lady with eGFR of 45. Okay, let's quickly talk about TAF. So I said it's available in the private sector, some provinces, hopefully it will be on tender soon, and it's available in different formulations. So we don't get TAF as a single drug in South Africa at the moment, as far as I know. We've got it in 3 different formulations in the private sector. We've got the TAF FTC combination. So it's almost like Truvada or Tenamine, but it's got TAF instead of TDF. Then we've got TAF Ed. So this is basically like TLD, but it's got TAF instead of tenofovir. It's got emtricitabine instead of lamivudine, and the D is dolutegravir. So still a 3-in-1, similar to TLD, just with TAF instead. And then we've got another 3-in-1 fixed combination with TAF, emtricitabine, and rilpivirine. So remember, rilpivirine is a cousin of efavirenz and nevirapine. It has been used in the private sector before. We've never had it in the public sector, but some patients in the private sector might be on this regimen. So this is what we have available in private. So TAF, what is TAF? TAF is actually a prodrug of TDF. It's more stable in the plasma, so it can deliver the active molecules to the cells better. So we actually need a lower dose of it than we do for tenofovir. So where for tenofovir we need 300 milligrams to have the desired effect, with TAF we only need 25 milligrams to have the same effect on the HIV suppression. So because we only have 25 milligram and not 300 milligram, you can imagine that the side effects are less. It might still have some of the same side effects, but to a lesser degree. So yes, it still can be nephrotoxic, but much less so. That's why we can use it down to an EGFR of 30. And yes, it can have some problems with the bone mineral density, much less so. So it's safer to use as an alternative to TDF. So if we have TAF as a single drug, we can actually use TAF down to an EGFR of 15. We can also use it in dialysis. You saw here on this slide, in South Africa, we don't have TAF as a single drug. So we can't use it down to 15. It's always co-formulated with emtricitabine in South Africa. And because of this limitation, that's why we stop using it from 30 and below. So as long as it's 30 and above, we can use it. Below 30, we don't use TAF because of the FTC that's co-formulated with it. So your FTC would need a dose adjustment. And we can't dose adjust that because we don't have singles of any of those. This would actually be a great choice in patients with hepatitis B, because it still has that same effect on hepatitis B that tenofovir has, but it's much safer on the kidneys. So if you have a patient with renal failure and hepatitis B, as long as the EGFR is above 30 in South Africa, TAF would be a perfect drug to use. Why don't we just use it in all our patients? Why don't we just throw TDF out the window and just use TAF? Well, because TAF also has some negative effects. It's not all perfect. It is associated with greater weight gain compared to tenofovir, and it can also have a bit of an effect on the lipid profile. So in those patients who are already overweight, already having metabolic kind of diseases, it might not be the best option. So it's great. We actually have options. We've got TDF, we've got abacavir, and in the private sector and in the future in public sector, we will also have TAF. So we can look at our patient and see, based on their renal function, their hepatitis B status, their metabolic status, which drug will be the best one for that patient. And then just a quick word about lamivudine. I showed you that we're supposed to dose adjust lamivudine if the EGFR is below 30. But there has also been studies done showing that if you have a problem and you don't have stock of lamivudine singles, and it's not your choice, but you are forced to give higher doses of lamivudine to a patient based on their renal function, it doesn't actually cause problems. So remember, lamivudine is a very safe drug. Lamivudine doesn't really have side effects. So yes, we are overdosing patients if they have a low EGFR and we give them a full dose lamivudine. But what's the side effect of being overdosed with lamivudine? Exactly, not much. So please do follow the guideline when the drugs are available. Give them the singles when you have the singles available. Know in the back of your mind that it's not the end of the world if you slightly overdose them, if you are really at wit's end and you don't have other options. I would be hesitant to give them the full dose if they are stage 5 renal failure, end-stage kidney disease. Really, I would prefer the correct dose adjustments. But you can always phone an expert or one of the helplines or your consultant or a nephrologist to discuss these patients if you really do have stock issues. But rest assured that we know that lamivudine is quite a safe drug. Okay, so we've spoken about tenofovir and the alternatives to tenofovir. What about other medications our patient might be on? So we are lucky that we don't need to dose adjust any of our other ARVs. DPG doesn't need adjustment. If they're on protease inhibitors, they don't need adjustment. And the patient that used to be on efavirenz or nevirapine, they also don't need any adjustments. Don't forget about cotrimoxazole though. If your patient has advanced HIV disease or they're on TB treatment, they're also on cotrimoxazole. If they've got stage 4 or stage 5 renal failure, we also have to adjust the cotrimoxazole. As long as the eGFR is 30 and above, you can give the full dose, which is normally 2 tablets a day, if you have the single strength tablets. And then if the eGFR goes between 15 to 29, you will halve the dose. And if the eGFR is below 15, we will avoid cotrimoxazole. So don't forget about these. We do sometimes see patients with advanced HIV disease, and one of the features that they have is that they also have renal failure. So just keep an eye on your Bactrim dose so that you don't cause toxicity. Cotrimoxazole does have toxicities if you overdose. So we really don't want to be overdosing cotrimoxazole. Okay, back to our patient. I told you that she's also hypertensive and diabetic. Both of those conditions are well controlled. The BP is fine, the glucose is fine. This is her current script. She's getting metformin 1 gram BD. She's getting glimepiride 4 milligram daily. She's getting HCTZ 12.5 milligram, enalapril 5 milligram, and diclofenac 25 milligram, because she's always complaining of her painful back and her painful knees. So for this patient, do we need to change anything? If you look at the script, if this is what the previous clinician wrote and today you are seeing her, will you repeat the same script? Will you add anything? Will you remove anything? So let's have a look. We have another poll. And the question is, how will you adjust our patient's chronic script? You can choose more than one correct option here. You don't only have to choose one. So if the first option is, will you stop all oral diabetic medicines and change it to insulin? Will you stop the glimepiride and monitor the HTT? Will you add amlodipine? Will you stop the diclofenac? You can choose more than one option here. Remember, her glucose and her blood pressure is well controlled at the moment. And she's very attached to her diclofenac. She's always talking about that bicycle tablet. Have you seen that box? It's got a bicycle on. She's calling it the bicycle tablets. She wants those bicycle tablets. She likes them. Okay, we've got some very interesting choices here. I'll give you a few more seconds and then I'm going to close the poll. So if you're still deciding, choose quickly and click submit. Okay, I'm going to pause it here. Sorry for those who were a bit late. Let's look at everybody's choices. So the winning option was stopping diclofenac. Almost 80% of you want to stop her bicycle tablets. She's not happy with you. Then about 40% of people wanted to stop all oral diabetic medicines and change it to insulin. And some people wanted the other options. Okay, I'm not going to give you the answer right away. Let's look at a few things first. Okay, so we've spoken about the ARVs, but we've said our patients have other chronic conditions as well. So we need to know how to manage those at the same time. So this is a reminder. This is from the EDL, your standard treatment guidelines. It's all there. You can go and check. It's not something that I came up with right now. It's in your clinic manuals. So metformin, as long as the eGFR is above 45, we can give the normal daily dose of metformin. If it's between 45 and 60, we know that's already a small sign of renal failure. If it's below 60, then we might monitor the creatinine a bit more frequently, but we can still give the normal metformin dose. If the eGFR is between 30 and 45, we will max the metformin at 1 gram per day. We won't give more than that. So we won't give 1 gram BD. We'll stop the metformin there. And if the eGFR is below 30, we actually have to stop the metformin. So for this lady, we don't have to stop her metformin yet. Her eGFR is still 45, so for her, she can still get her normal daily dose, but we will just have to keep a close eye on the creatinine to see what's happening there. Remember before, last year, 2024, her eGFR was actually 41. So then we should have actually decreased her metformin a bit. But luckily now the kidneys have improved a little bit without us changing anything. So she's still eligible for the normal dose of metformin. What about the sulfonylureas, drugs like your glimepiride or glyclazide? Those we should actually avoid if the eGFR is less than 60. And these often slip through the cracks. I see many patients at the clinics who are still on high-dose metformin and high-dose glimepiride or glyclazide, even if the eGFR is a bit low. So it sounds a bit harsh, but you would, for this patient with a GFR of 45, you would have to stop the sulfonylurea. And then we'll have to see what happens. If the sugar remains controlled, maybe she'll be fine on metformin alone. If the sugar goes up, we might have to consider adding insulin down the line. We don't necessarily have to add insulin right now, but we have to keep a very careful eye on the glucose because we've stopped one of her glucose drugs. Then looking at the diuretics, the thiazide diuretics, this is things like Redac, HCTZ. They don't get toxic as such, they just become less effective if the eGFR is lower. So if the eGFR is less than 30, you can give all the HCTZ that you want. It might not really have much of an effect. You might as well stop it. So then it's better to switch to a loop diuretic. This is a drug like Lasix, furosemide. So rather give furosemide in your patients with eGFR less than 30 rather than Redac or HCTZ. Then ACE inhibitors are good for people with mild renal or with renal failure, but it can also push the potassium up. So we have to balance the drugs like enalapril a little bit. So we'll start on a low dose, monitor the potassium, and decrease or stop the enalapril if the potassium goes to above 5.5. A high potassium can be quite dangerous, so we don't want a high potassium. And then our NSAIDs, unfortunately, we have to avoid all these NSAIDs drugs like Brufen, diclofenac. She wants a Voltaren injection. Sorry, not today, not with this renal function. There's other drugs as well. Gabapentin, some patients are on it. Allopurinol for those with gout that might need dose adjustment. There might be other drugs as well. I couldn't list every single drug that needed to be dose adjusted. But the important thing is if you do have a patient on a long list of medications and they have renal failure, do check those drugs, especially the ones that we don't use often. The common ones, we tend to recognize them and know which ones we can use and which ones we need to stop or adjust the dose. But if the patient is on some interesting other drugs that you don't always see, please look them up and see if they are safe in renal failure or if they need to be adjusted. So back to our poll. These were the correct answers. Number 2, stop glimepiride and monitor the HGT. We might have to add insulin in future if the glucose becomes uncontrolled. And then unfortunately for her, we have to stop her diclofenac. We can give her alternatives. Panadu, they don't always like paracetamol by itself. They say it's not effective enough, but that is a safe drug in renal failure. And yeah, we might have some other options available as well, but definitely not NSAIDs. Then there might be some additional things we can add as supplements in patients with chronic kidney disease. And this is to support the organs that are struggling because of the renal failure. It supports the bone health and it avoids them becoming anemic because of chronic kidney disease. So you don't have to add all of this for every patient with renal failure. It will depend on the level of renal failure and the duration of symptoms, but you can consider adding things like iron tablets, folic acid, calcium tablets, vitamin D supplements, and a PPI if we think they have gastritis. So not for all patients, but some patients might benefit from these sorts of supplements. And we said our patient is at the clinic. So when do we refer to hospital? And again, the first most important thing is follow your local referral policies. We are people from all over the country here, all different provinces, and there are different referral protocols in different places. So please don't shortcut anything. Follow your local policies. But these are some suggestions. So if the creatinine is rising and it keeps on rising, the trend shows creatinine is going up, 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 eGFR is going down, 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 rather refer to the doctor or the hospital sooner rather than later to find out if there's a reversible underlying cause. If the eGFR is below 30, guidelines actually say if the eGFR is below 30, the patient should be seen by a nephrologist. I think that sounds lovely, but not all of us are in centers where we have easy access to a nephrologist to send every single patient to a specialist. But at least they should be seeing a medical officer, a medical doctor, if the eGFR is below 30. Stage 4 and stage 5 kidney disease shouldn't only be managed by a nurse at the clinic. You can start your management, get input from a doctor. Patient might continue following up at the clinic, but there should be a plan with some input and some investigations from the medical officer. And then obviously if your patient is unwell, if they are acutely sick, they are septic, they are, you can see the person is not looking well, because there might be things we can pick up. And these are things we might test for at the hospital. They might be hyperkalemic, they might be acidotic, they might have pulmonary edema, they could be bleeding because of this coagulopathy you can get with renal failure, and they could have an encephalopathy. So they could be confused, things like that. So these sorts of patients definitely should be referred quite urgently. But phone for advice, your local referral center, your local doctor, to check if there's anything you can do before you send, or how quickly you should send, and what part of the hospital you can refer to. Okay, then we are not too far from the end. I want to mention the dolutegravir effect. I don't know if any of you have heard of the dolutegravir effect. So what happened is, in clinical trials, when they were still doing lots of trials on dolutegravir to see if it works for viral suppression and everything, they did notice that there are small increases in the creatinine. Usually it was an increase between 10 and 20 micromoles per liter from the baseline until when they started the tenofovir. And this happened in everybody on dolutegravir. So it was a trial, so they were able to do bloods very often, almost daily or weekly, not like in our setting where we do it according to the guidelines. So because they were checking things frequently in the trials, they did notice that the creatinine starts rising in the first week that the patient is on treatment. And this is because one of the cation transporters in the kidney is actually inhibited a bit. It doesn't work exactly how it should. And that specific transporter is supposed to secrete the creatinine. So it's not actually, you don't have to understand all of this, but it's not actually a sign of renal failure. It's basically just that the creatinine gets excreted and then it almost gets absorbed again and has to be excreted for a second time, something like that. So it doesn't actually affect the glomerular filtration rate. If you remember what the nephron looks like, this picture here on the side, you've got the glomerulus here and the filtration rate from the picture is not clear, but here's the glomerulus. It will filtrate here and then it will move to the urine, to the bladder. So the dolutegravir does not affect the glomerular filtration rate. It does increase the creatinine slightly. Might be a bit complicated to understand, but rest assured the dolutegravir does not cause renal failure, even though it might increase the creatinine slightly. So how do we know whether it's the dolutegravir effect, which is not a problem, or if it's actual renal failure, which is a problem? So here's some clues. The typical picture that we see if it's the dolutegravir effect, that the creatinine will be normal, or the eGFR will be normal at the baseline before the patient starts dolutegravir. Then when we collect our next creatinine after 3 months on dolutegravir, the creatinine might be slightly higher. It won't be higher than 30 micromoles compared to the previous. So if the baseline creatinine was 80, then at 3 months, it must not be higher than 110. If it's 120, it's more than 30 increase from the 80 that we started with. That is not the dolutegravir effect. It's not a mild increase of less than 30. And another clue is if we repeat the creatinine again, it will be on a similar level. It won't keep trending upwards. So if it went from 80 to 100, It will stay at 100, it will stay at 100, it will stay at 100 again. It won't go to 100, 120, 140, 160. If we see a picture like this, that will lead us to think it is just the dolutegravir effect, which is not dangerous. Things that give us a clue that it's not the DTG effect is if the creatinine rises with more than 30 after we started dolutegravir, or if the creatinine keeps rising, it doesn't flatten out, or if the creatinine going up is not associated with starting dolutegravir. Maybe the patient has been on dolutegravir for a year or two already. Previously, the creatinine was normal, and now suddenly it's starting to go up after 2 years. That's not the DTG effect. The DTG effect happens in those first few weeks when you start taking DTG. Won't happen later down the line. So if you see it later on, definitely there's something else happening that we need to look for. Don't blame the dolutegravir. Look at the tenofovir, look at the diabetes, look at all the other issues that we were discussing earlier to find your underlying cause. Okay, somebody did ask about hepatitis B in the chat. I mentioned it briefly when I spoke to TAF, but let's have a proper discussion about hepatitis B positive patients who have renal failure, because that's always a tricky one to manage. So the good thing about tenofovir is that it treats both HIV and hepatitis B. But now we have this conundrum. We've got chronic renal failure, so we have to decrease the tenofovir. We have to keep the tenofovir there. We have to decrease the dose because of the renal failure. So if you have a patient with both Hep B and renal failure, this is your cheat sheet, how you can adjust it. So if the eGFR is between 30 and 50, we can give tenofovir every second day, or ideally, we can use TAF instead of tenofovir. This will be the best solution because you can still give the patient 1 tablet once a day, simple regimen, if the eGFR is between 30 and 50. So if you're in the private sector, please go for TAF for these patients, or later on when we have TAF available in public sector, you make use of TAF in this case. If the eGFR is between 10 and 29, now we can't use TAF anymore. We have to use TDF, and we still have to decrease the dose. Then we can give the TDF twice a week. And if the eGFR is less than 10, we can give it once a week. Okay, but now we have a tricky scenario because we don't always have all the singles available of all these drugs. Who still has TDF 300 milligram single tablets in their facility? Probably not too many of you. So here's a practical tip. The best plan is to use dolutegravir 50 milligram daily, and then use your TDF-FTC combination on the indicated days. The FTC also has the same longer half-life than tenofovir if there's renal failure. So you can stretch both of those in the same way. So if the eGFR is 8, you will give DTG 50 milligram daily, and you will give TDF-FTC once a week. And that is enough to treat the HIV and the hepatitis. You don't need to add a backup to that additionally. TDF is not excreted the way it should because of the renal failure. So the levels will be appropriate in the body for the whole week. So it's fine for HIV and hepatitis. This can be a bit confusing. It's not written in the guideline exactly like this. It might be mentioned in the new advanced HIV disease guidelines. It will come out later in the year, but it's not in the 2023 ART guidelines. So if you have a patient like this and you are unsure, please rather call for advice. Like I said, call one of the helplines, call your local expert, call your consultant, let them guide you on how to adjust the dosages so that you don't make a mistake. And then lastly, what do we do if we have a low creatinine? Because I often get calls about people saying, I think I should stop the tenofovir because the patient has renal failure. And then when I ask the results, the creatinine is low and the eGFR is above 60. So what does that mean? Remember, creatinine is a waste product. The waste product should be excreted by the kidneys. So if the kidneys are not working well, the waste product will be building up and it will be high. But if the creatinine is low, what does that mean? It means the waste product is not produced in the first place. And creatinine is a waste product from muscle breakdown. As we are exercising, as we are moving our bodies every day, naturally some of our muscle fibers are breaking down, and that waste product becomes creatinine. So having a low amount of a waste product has got nothing to do with how the kidneys function. It's got to do with the fact that you somehow in your body you are not producing a lot of this waste product. So this sometimes happens in people with a low BMI. They don't have a lot of muscle. So there's not a lot of muscle that breaks down on a daily basis. So there's less of a waste product. It could also be in people who eat a low protein diet. Proteins in the diet is not there, so it can't be broken down, so it can't be there as a waste product. Even in pregnancy sometimes, because the body, the blood volume gets increased, it can be a bit diluted, so you might see a lower creatinine in pregnancy as well. So this is not actually a clinically important thing, unless it's extremely low. Maybe you've got a very wasted patient. In that case, a low creatinine might be something to look at as part of the general picture of the patient. But in the vast majority of cases, a low creatinine is not something we need to worry about. It's not something we need to do anything about. And most importantly, it's not a sign of kidney disease. So we do not have to stop our tenofovir or any other drugs if we see a low creatinine. It doesn't reflect on the kidney function at all. So that's good news. We don't have to worry about this. We can just be happy if we see a low creatinine. So that is my story for the evening. I hope you all got something from it. I'm happy to take some questions. Don't ask me difficult questions because I'm not a nephrologist, but I'm happy to take some questions on the side. Thank you.
Thank you. Thank you so much, Dr. Christie. I can tell you there is so many questions. So I hope you are ready. I don't think they are very difficult, but I think we have enough questions. Actually, I had written mine, but I think I can always, I don't know, reach out and stuff. So I think we will just prioritize questions from everyone. Maybe rather than me asking Christy, do you think you can maybe focus on the Q&A tab and just go through them as they come? Because I think if I start asking, it might take us a little bit longer to go through all. I don't know. What's your take?
Yeah, we can do that.
Okay, yeah, I think you can start, and then I will just highlight few that are maybe on the chat after you have done with the Q&A. Yeah, and then colleagues, we don't have a hard stop at 8 because the diplomas are paused, but we still have a target to try and finish around 8. So we'll see how far we go. Yeah, Dr. Christie, we can go through the Q&A tab, and then let's see how far we go. Thanks.
Great. Okay. The first, I don't know if I can answer all these questions, to be honest.
I'll be with you.
The first question is, what is the difference between the Kuna and Barrett formula and the Cockcroft Gold formula? I used to know this. I don't have them right in front of me right now, unless I Google them quickly. I would suggest you just Google them. It just uses slightly different inputs. I don't have it right in front of me now, but it's easy enough to find. Sorry, maybe I should have put them on a slide so that we can just all look at them together.
Yeah.
Then somebody is asking very
Can I
clever
just
questions,
add
yes?
a quick one on that one? Also to say that some formulas are validated for countries outside of South Africa. And because of dietary differences, you'll find that one formula is preferred for a certain population. So it's also important to pay attention to that. Yeah. Thanks, Christy. You can continue.
Yeah, thanks. Somebody is asking, when do we use the Schwartz formula? I've not heard of the Schwartz formula. You might have to ask your local nephrologist that question.
Yeah, but it's the same.
Can look it up.
It's the same
Is it?
because the volume, yeah, I'll just say the amount of protein that different countries and stuff consume is not the same. So I think out of all those formulas, South Africa tends to be using the Cockcroft formula versus any other formula you can use for the creatinine clearance. Yeah.
Okay.
Yeah.
And there's a question whether ALD with decreased dosages is available as a single drug. So a Bacavir 600, lamivudine 150, and DTG 50. Not as far as I know. It would be great if the drug companies can make something like that for us with our renal patients, but I don't think that's available. Unfortunately, if we start having to decrease lamivudine doses, we are forced to go back to the singles at this point. Okay, somebody else is asking, do we really need to reduce lamivudine if the eGFR is greater than 15? I don't know if that's supposed to be less than 15. There's a lot of evidence that it's not toxic. Single drugs may do more damage. Okay, I don't know when this question was typed. It might have been before I showed you that slide. So I think I did clarify that lamivudine is not a very toxic drug. So if we are having issues with supply, then we might have to give a higher dose, and we don't really expect too many problems with that. But to cover yourself, because that's not what the guideline is saying, to cover yourself when you do something that is not in the guideline, please do discuss it with someone more senior than you. So the helplines, the referral center, the specialist, somebody should just give you that permission so that you can be covered in case anybody is querying what you are doing. Okay, there's a question about low eGFR and hepatitis B. I hope you were answered towards the end of the presentation. So you can type your question again if you still had a question, but I'm hoping that was answered. There's a couple of questions about that, actually. So I think they were answered. Okay, somebody is asking if the eGFR is less than 60 and Bactrim can't be given, then what's the alternative drug for patients with low CD4s? Okay, so remember, we really can't give Bactrim if the eGFR is less than 15, 1.5. So a slightly low eGFR, we can still give Bactrim. If it's above 30, we can still give the normal doses of Bactrim. Between 15 and 29, we give half the dose. It's only those with a really low eGFR below 15. And I think, unfortunately, for those patients, even dapsone is contraindicated, if I'm not mistaken. So it is a bit of an issue. If they really have low CD4s or other comorbidities like TB and they've got end-stage renal failure, that's quite a tricky patient. But I don't think we really have a specific general prophylactic that we would then be able to give, unfortunately. Okay, then there's a question about the metformin doses. The question is saying, if the patient was on metformin 850 milligram TDS for some reason, can we rather change to 850 twice daily or keep the TDS? Okay, I think it will depend on the glucose control and everything. If she's well controlled on her dose, you don't really want to change it too much. But if she's on metformin 850 TDS, that will be a bit too high if her eGFR is 45, like the one we had in the case. So that one we would either have to take down to what were the options again? 1 gram BD or 500 BD, so it's 1 gram a day. It will just depend exactly on the eGFR and on the glucose control. So you could have more than one option, but I think 850 TDS might be a bit on the high side, but it will depend on the exact patient. Then there's a question again, if it's an elderly patient with eGFR less than 40 and diabetic, would we follow the same protocol? I'm not sure exactly which one you are referring to. If the eGFR is less than 40, there are certain things that we can and cannot give. So I don't think the age or the diabetes would necessarily change anything. But maybe, Simo, you can just clarify your question there. Okay, Mbali is asking if the client's creatinine clearance starts by being maybe between stage 3 to 1, and the medication is adjusted, and if the creatinine improves, do we readjust the dosage? Okay, that's a good question. So the kidney, the renal failure level is changing. So it can improve or it can worsen. So if the renal function is worsening, we have to keep on readjusting the dosages so that it's appropriate. If the renal function improves, we again have to increase our doses. So let's say we gave a low dose of lamivudine because the patient had a low eGFR. Now it's improving a bit. We have to increase the lamivudine dose again. Otherwise, we'll be underdosing the patient. The more tricky question is, when can we retry tenofovir? Should we retry tenofovir if the kidney function is now completely normal, or should we stop the tenofovir and like permanently? And that's also a bit of a case-by-case basis. So if it was someone with an acute renal failure, Maybe they were quite sick when you found them. They were having some diarrhea. They were dehydrated. They had some other issues happening. We will definitely stop the tenofovir if they've got renal impairment, put them on a renal-friendly regimen. But now it's a year, 2 years, 3 years later, they've been completely fine. The renal function has been normal for a while. We think that the original cause is not there anymore. That's a patient that could do very well with trying tenofovir again. But then you get other patients, they might be elderly, they might have diabetes, hypertension, other comorbidities. You see they're on tenofovir, you stop the tenofovir, and the creatinine function improves slightly. It's now normal range. So what do you think will happen if you add the tenofovir back? It might just decrease again. So it's a bit of a case-by-case basis, depending what we think the cause was. Do we think the tenofovir, the kidneys will manage this time around with the tenofovir, or do we think the same thing will happen? Sometimes it's a bit of trial and error. If you retry the tenofovir, please keep a very close eye on the creatinine to make sure it doesn't become abnormal again. But it kind of depends on the story of the patient and what. Okay. We've got a question. Okay, there's a question about the single and double strength cotrimoxazole. I also don't know exactly what the question was. Chekofatso, if you want to elaborate a little bit what exactly you mean with the cotrimoxazole dosage. Then we've got a question from a clinic doctor. I'm curious about using abacavir in patients with renal dysfunction and on TLD2. Can we use abacavir in second-line patients? Yes, so we can. So we know that abacavir has a slightly lower barrier to resistance than tenofovir. It's not quite as robust as tenofovir. But in patients who are on second-line TLD, if they can't use tenofovir, for now, abacavir will be our option. When we have TAF available, then TAF might actually be a better option than abacavir for our second-line patients, TLD2. But I'm sure when we start getting TAF available, the guidelines will be clear to guide us on which patients will be eligible for TAF exactly. But for now, if you can't give tenofovir, you will give abacavir. We know that it is possible to get resistance to dolutegravir if you're on TLD2, and it might be ever so slightly more likely to get resistance if you're on ALD instead of on TLD. But that is the best regimen we have at the moment. So we will give it, and if they start having treatment failure, we'll cross that bridge when we get there. For now, if they're having renal failure, we will give them abacavir instead of tenofovir. Then there's a question about the fluid challenge. Does the fluid challenge work for patients with renal impairment? We normally tell all patients with renal impairment to drink water and repeat the blood stream monthly. So, yeah, I see that often in the clinics as well. This is probably more applicable in acute renal failure. Someone who's dehydrated, quite sick, giving them some fluids will help the kidneys to improve a bit. Chronic renal failure, I don't necessarily know if just drinking water will solve the kidney problem. And I've seen it a lot when I look at patients' files. The eGFR has been below 50 for the last 5 years, and every visit there's advice given to drink more water. So we all agree that we should all be drinking more water than what we do, but drinking more water is not going to solve the problem if there's a mass obstructing the kidneys, or if there's another condition that is damaging the kidneys. Then we have to find that other condition and manage that if we can. So yes, for the acute renal failures, definitely let them drink more water. Everybody should drink more water. That's general good advice, but it's not necessarily going to solve renal failure. And then there's another question. Is there a set duration on when to repeat creatinine once we see it's less than 50? Again, it kind of depends on the level. If you do a change, so let's say you change from tenofovir to abacavir, then repeating it after 3 months would be a good idea, because you want to see, is it still going down? Is it getting worse and worse and worse? You need to escalate your treatment to a higher level. Or maybe it's improved now, and you can either re-challenge tenofovir, or you can be happy that abacavir is the great best drug for the patient to be on. But then it might be different if the creatinine is sky high and the EGFR is 12, for example. You're not going to wait 3 months to repeat that. So it kind of depends on your clinical picture and the exact level of the creatinine. But for a fairly stable patient, 3 months is probably a good idea, especially if you are still busy tweaking your management. Once they are stable, you might do it less frequently, maybe every 6 months or so. Okay, here's a question that I think I've spoken about. Can you ever change from ALD to TLD if the renal failure improves? So your example is exactly right. If you initially had a dehydrated patient with acute renal failure and they recover, that would be the perfect kind of patient that you could re-challenge it enough of a later on, because we don't think there's ongoing renal failure. The next question is about what's the risk of hepatitis flare-up in severely reduced tenofovir dose in the patients with hepatitis B. I can't give you a percentage exactly. It is a theoretical risk. I must say I've never seen a hepatitis flare myself, but then I also don't necessarily work in the gastroenterology wards or surgical medical wards where you might see this if it happens. So yeah, there is a theoretical risk that we could get a hepatitis flare-up if we stop tenofovir or underdose tenofovir in someone with hepatitis. That's why we do try to keep tenofovir in the mix. But I don't think it's a super common thing. We've all seen people with Hep B positive who did not have tenofovir with their renal failure, and many of them were fine. So we're not going to take the risk and just not give tenofovir because some of them might complicate. But it is not a very common thing in my experience. Okay, here's another question saying, this person says, I've been taught not to accept the EGFR result on the lab report. We use the MD Calc app to calculate the creatinine clearance using creatinine, sex, weight, and height. Is this incorrect? No, I don't think it's incorrect. I would be interested to know, do you get many different results based on the EGFR on the lab report? Because I think it might be worth calculating if you see lower levels of creatinine. Then it might be, more useful to see if you get something different. I don't know which formula this app uses exactly. I don't think that's incorrect necessarily, but for the majority of our patients, if the creatinine is normal, the lab result one is completely fine. So the lab won't tell you the EGFR is greater than 60, maybe it's 100 or something, and then you calculate and you get 20. So it won't be huge differences like that. It will be minor differences. So if you are in a site where everybody is using the app and the formula is applicable to the South African population, then I don't see a problem with it as long as you document in your notes where you are getting your results from that you are basing your treatment decisions on. Elizabeth is asking, does tenofovir-induced nephropathy cause chronic kidney disease or is it reversible? It can be reversible. That's why sometimes if we stop the tenofovir, the renal function improves. So I think it depends how long they were on tenofovir and if there's other additional things also contributing to the renal failure. The kidney disease might not normalize completely if there are other causes as well, but it can improve if tenofovir was a contributory cause.
Dr. Christie, as you take some breathing time, colleagues, it's the last 5 minutes because I see your questions keep coming. We will see how we respond to most, but I think most of the questions are very, very similar. Just also to remind you, those of you who are joining us for the first time, that welcome to the Clinical Care Platform, and I hope that you have found this session to be of great value to you. Do support the platform by visiting our website, joining membership. You have an option to join the annual subscription or even the monthly subscription so that we can continue to bring you this awesome educational experience. Yeah, I wanted Dr. Christie to take a deep breath as we go for the last mile for the last 5 minutes. Yeah, thanks, Dr. Christie.
Thanks. I see there's still a lot of questions left and they keep coming. Are there any specific ones you want to point out? Should I just take them from the top and see how far we get? Or are there any specific ones that look interesting?
Yeah, there's a question more on advanced HIV. Mtogozi is asking about the approach if it's HIV versus kidney dysfunction. And he says since both may present with abnormalities in the EGFR. Yeah, I think it's a question more about other secondary causes more than it, because HIV will be a secondary cause, not necessarily a drug-related cause, right?
Yeah, so if it's really high van, and it's not always easy to prove that it's high van. If it's high van, usually they will present with renal failure from the start, because it's the HIV that caused the kidney disease. So you will already find them with high van when you are diagnosing the HIV before you even start adding tenofovir. And I think generally they've got enlarged kidneys on ultrasound. So we don't always have a baseline kidney ultrasound to see exactly what was happening. So sometimes we make an educated guess and we say we think it's high van, and then the label gets put on the patient. But if it's really high van, sometimes the renal function improves a bit once the HIV gets under control. So once you put them on an ARV regimen, the viral load suppresses, the renal function might improve if it was HIV-associated nephropathy. So if it was a different cause of the renal dysfunction, you might have a different effect. Getting the viral load suppressed may or may not then affect the renal function. So if you talk about treatment or management, from the ARV point of view and from dose adjustment point of view, the cause doesn't really make a difference, how you adjust your drug dosages, but your other management, your workup, your investigations, your treatments of other causes might be different based on the cause. I don't know if I answered that properly, exactly what you were asking.
Yeah. I think that's awesome. But I see
be...
there's a whole lot of questions about this metformin and what you call DTG. I've actually pulled
Can
out.
I talk about that?
Can I share
Yes.
that Cape Town current advice? I don't know if our guidelines are already there.
Yes, please.
And then maybe you can explain it, because I've tried to search for it. If you can stop sharing on your side, and then once I show it, you can then maybe take the colleagues through that particular section, because I think almost everyone is stuck on the. Krista, are you able to? I'm not able to. Let me see what I might do. Oh, it's because of, sorry, it's on my side. Sorry, I've done. I don't know if you are able to see it. And then I must just zoom in. Where is it? Where is the metformin thing? Is it this part, right?
It's right there. I can see it in the middle.
Yeah,
I can see it there.
Yeah, let me, because I want them to focus on. Okay, I'll fix it. But yeah, I don't know, Christy, if you wanna.
So this is the good news.
Yes, thank you.
This is the good news. So remember when we started getting the 2019, 2023 guidelines with dolutegravir, we were all told that metformin can't go higher than 500 BD because dolutegravir increases the metformin levels and we could have metformin toxicities. But now we've had a few years of experience and we realized that it's actually not a very common thing. When anybody on metformin can have metformin, that we have to think about that in the back of our mind on all of our patients. But if they're on DTG, which pushes up the metformin, they are supposed to have a higher risk of having these complications. So that's why the guidelines said stop at 500 BD. But now we've had some real world experience with thousands and thousands of patients on tenofovir, on dolutegravir and metformin in the country. And we've not really seen those side effects come up as much as we theoretically expected they would. So I think it's at the end of 2024, the guidance has actually been changed. And you can see here in the middle of the slide in that block, it says we should initiate metformin at a low dose, which is 500 or 1,000 milligram total daily dose. We can titrate up as needed based on the glucose control, and we should not exceed 2 grams daily. That's the great new part. Instead of 1 gram daily, 500 BD, we are now getting up to 2 grams daily. So you can give 1 gram BD or 850 BD. Those are still fine. If that's what's needed to get the glucose controlled, you can go up to there. So there's some more details there. about the initiation. So if the patient is already on metformin, now you are starting dolutegravir. If the person is on a lower dose metformin already, you can continue on that dose, lower meaning less than 2 grams daily. Check if they have any side effects. If they're on more than 2 grams daily, so basically if they're on 850 TDS, then you should reduce the metformin to 2 grams daily. So then you can give 1 gram BD, for example, monitor them, and then take it from there. Obviously, like we spoke about now, if they've got renal impairment, we also have to dose adjust the metformin based on the EGFR. So they are reminding us there that the metformin should be avoided if the EGFR is less than 30. Because then if you are overdosing metformin based on the EGFR, you also have a higher risk of getting those side effects. So ask all your patients about side effects, but if they are on DTG, we can give a higher dose as long as they are not having any problematic side effects.
Thank you so much. I think that sort of closes this. I don't know what to call it because there was just so many questions about it, and colleagues just kept on asking, like, "Oh, why?" Yeah, colleagues. On that note, just to say thank you to you. Thank you so much for joining us this evening. I know there's a lot of questions, but I think we have managed to do as much as we can. And at the end, we dealt with what I think was one of the most trending question, if I was to say that. Dr. Christie, thank you so much for your time preparing, but also coming here to empower us and spending almost 20-25 minutes just responding to the questions. After saying a lot of things, colleagues may leave with a lot of things. Is there one thing as you do your closing? Also, maybe share 1 or 2 things that you really don't want us to forget, and then we call it a night. Thank you so much.
Sure, now I must think quickly.
Yeah, sorry.
I think the main thing is remember that there's lots of main things, but one thing is remember that there's different causes of renal failure. Renal failure is a symptom of an underlying disease process. So we can't ever just diagnose the patient with renal failure and then say they've got renal failure. We have to try and think, is it acute? Is it chronic? Is there anything we can do to make it better? So keep that in mind. And then look at all the medicines that the patient is on and make sure they're getting the right drug at the right dose, and that we adjust it as needed as the kidney function improves or deteriorates. Let's not overdose or underdose our patients, and ask for help. Like, none of us are, well, I'm not saying none of us, maybe there's a nephrologist on here or a physician, internal medicine specialist, but most of us are not kidney specialists. So don't be afraid to ask advice. Ask your colleague, ask your visiting doctor, ask your referral center, ask whichever specialist or helpline you want to ask. We are all learning together, and asking for advice is always a good idea if you are not sure.
Awesome.
Thank you so much. It was a great evening with all of you.
Yeah. At some point, we had over 1,000 people. I think it could have been more. I think our Zoom account was blocking some people. They won't be happy with me. So we'll have to look into that. But yeah, thank you so much, Dr. Christie. Colleagues, thank you so much for making it. You have made us feel that it's valuable and that you would want to have more of these sessions as the year starts. And yes, we are planning to do so. May I wish everyone a restful night. Don't forget, we have another session tomorrow looking at congenital disorders. This is our collaboration with National Department of Health managers, bringing you some of the important topics. Please don't miss it. And then I think on Thursday, we are back with gynae oncology. And next week, we've got some child health stuff coming. I told you we are going to bring the pediatricians here. It's going to be awesome. It's going to be an awesome year. I hope you are ready to elevate your growth and capacity to serve our people. Night, everyone. Bye. Have a great one.
Welcome, and thank you for joining us today. In primary healthcare, we're often the first point of contact and the steady presence patients rely on. When HIV and renal impairment intersect, the decisions we make become even more critical. Today's session explores a practical PHC approach, early identification, appropriate monitoring, and treatment considerations that support safe, effective care. Because behind every guideline is a person, and behind every decision is the opportunity to improve outcomes.